The VERTIS-CV trial looked at the latest of the SGLT2 inhibitor class, ertugliflozin, and studied it for cardiovascular safety as is required by FDA. And we did, in fact, find that it was for MACE, the three-part endpoint of cardiovascular death and MI stroke, as compared with placebo, in patients with atherosclerotic cardiovascular disease. About 8,000 or so were enrolled. We then went on to look at some of the other endpoints that had been seen in other trials, cardiovascular death or hospitalization for heart failure. We found a trend, but not a significant reduction in that endpoint. We then also looked at other components, but they're not testing statistically since that first endpoint wasn't significant. But we did see about a 30% reduction in hospitalization for heart failure that would have been statistically significant. And then trends also on improvement in renal function over time, or less worsening of renal function as is seen with this class of drugs. Then putting this in perspective, we did a meta-analysis of this trial with all the other prior outcomes trials and found that the pattern that we saw was very similar to the overall pattern. And so there's a modest reduction in MACE for the class as a whole, and then overall a reduction in cardiovascular death, although some heterogeneity with just the first trial showing benefit and as an outlier from the others. But then hospitalization for heart failure has been consistently seen across all the trials, and improvement in renal function. And so these data and the meta-analysis really provide strong support for the current guidelines that have shifted in the last year or two to recommend using the SGLT2 inhibitor class for patients with atherosclerotic cardiovascular disease, heart failure, and for those with chronic kidney disease. So we hope that these results can help reaffirm this and help all of us begin getting this to our patients so that they can get the benefit of them. The safety findings were very similar to what's been seen in prior experience with this drug and with all the other class, so that mycotic genital infections are the most commonly seen side effect, and those were higher with this agent, ertugliflozin. Urinary tract infections also tended to be higher, and acute kidney injury was not different, however. And so, and indeed, as just mentioned, there's actually improvement in renal function over time. Diabetic ketoacidosis was seen at a higher rate, although thankfully very rare. So it's in the 0.1% or 0.2% range. So very low, but definitely something that one has to keep an eye out for. So I think a very similar profile to what's been seen with all the other agents. Well, very good question. And indeed, as mentioned, we did a meta-analysis to try and see where does this trial fit in. And basically the pattern that we saw was identical to the overall pattern for the class. Although, as noted, the statistical significance of individual endpoints was not seen for superiority in this trial. So we find that it's really consistent and adds support for the class of drugs overall, so that hopefully this can add further support for the use of these agents in our patients in day-to-day practice. So for the statistical significance within this trial, I think we've tried to look at whether the drug was different, and pharmacologically and specificity, it's almost identical to other agents in the class. The pharmacologic effects, that is on hemoglobin A1C, blood pressure, weight, are all almost identical to what's been seen in the other trials. Our patient population is also pretty similar. It was an atherosclerotic cardiovascular disease population. And so we came out of this looking at, confidence intervals to say that any benefit that's seen has a confidence limit around it. And we tended to fall on the lower end of a confidence limit, I think, as the explanation. And, looking at the overall pattern, not all the trials were positive on all the endpoints. The first trial was on those 4 endpoints we discussed, but then the second and third and fourth trials had differences of which endpoints met significance or not. We tend to sort of forget it since we see the pattern, and so we fit into that pattern overall, but not statistically significant for superiority on our pre-specified secondary endpoints. Well, in choosing between drugs, I think the first question is actually to choose the class, and that's probably the biggest area of focus, at least for me, is as I'm seeing patients in the office, remembering, wait a minute, this patient with diabetes, their EGFR is 45, they have chronic kidney disease, so I got to start thinking about it. Or, more commonly for me, they have prior MI, or we've had a stent in the past, so they have atherosclerotic cardiovascular disease. They really should be on an SGLT2 inhibitor. So choosing the class, I think, is a key. And then working out with their primary care doctor, if they have an endocrinologist, making sure it's appropriate and you coordinate care. And in the United States, the choice of agents is often not ours, and it's dictated to us by the patient's insurance, which is kind of infuriating, but it's the world we live in, so that often the choice of the actual drug is one that's dictated by the insurance, and we have to figure out which one that is. That's probably a little less important, and more important to try and look at whether the class is relevant for different patients. And I think we'll see that probably half of my practice, could be on one of the new classes of drugs for different indications. And that's the exciting thing, is to try and offer the new research to each of our individual patients.